Okay, welcome. Hi, Carl. Welcome to Center for Global Development. When you speak, I guess the mics are already on, so we don't have to worry about putting it on. Thanks to those who are joining by the webcast. I think this is a really important paper that Sanjeev and Helene have been working on for some time. They've presented it once before at the WHO Health Financing meeting in Montreux. And you know, domestic resource mobilization, it was obviously one of the big recommendations that came out of the Addis Financing for Development meeting. It was the solution that was given for the sustainability of many of the big global health efforts that have been financing recurrent costs in the health sector appropriately. And there's been, I would say, an explosion of initiatives around DRM focused on health in particular. And I think the work of Sanjeev and Helene is going to reflect on this and how we think about these issues and what the role is for those of us who work in the global health sector going forward, and also a more realistic understanding of what the prospects are for growth in public spending on health over time in some of these countries. So without further ado, I'll hand it over.
I think
Helene's going to start?
Helene is going to start.
Excellent. We'll start with Helene. She's a senior health financing specialist at the WHO in Geneva. And Sanjeev is a senior policy fellow here who's been working on fiscal policy in low and middle income countries and on domestic resource mobilization, the political economy of domestic resource mobilization. We're not going to talk about that today, but I encourage you to come back for that work later. We've just published a number of case studies from sub-Saharan African countries on prospects for DRM and constraints, which is quite interesting. So let's start then with Helene.
Thank you, Amanda, and good morning, good afternoon, everyone. I'm very, very pleased to be presenting the preliminary findings of this work with Sanjeev, as you said, from the Center for Global Development. So I'd like to start by giving you some background on how actually we started working on this project. So I think many of you who are with us today for this session, either connected or physically in DC, were also actually with us for some of the initial discussions we had on the importance of fiscal space and fiscal space for health, or I would say within the health sector. And I think in those discussions, we very much all agreed that the development of the initial framework, right? So the initial framework that was developed some 15 years ago already, right? So that the development of this initial framework was a significant conceptual progress or conceptual advancement. I think the initial framework was, and probably I would say still is, a powerful tool to really help understand how health reforms fit within the broader macro-fiscal context, right? So I think the framework at that time, when it was developed 15 years ago, really helped those of us, including myself, within the health community to really deepen our understanding of macro-fiscal reality, right? But I think also that in our most recent discussion, as you mentioned, during, for example, the Montreux meeting last November, I think there was also a growing, I would say, consensus, or at least understanding that we need collectively probably to work further and probably to work to translate these concepts of fiscal space for health into something more practical, into practice. And I think this is really the main reason or motivation why we decided to start working on this project at the beginning. So I think we wanted with Sanjeev to really provide concrete inputs, right, that would support the operationalization of the concept of fiscal space for health. And I think we hope that with this work, we can help very modestly, but can probably contribute to help countries identify really the policy levers that are behind the increase of fiscal space for health, and thereby can clarify, as you said, Amanda, clarify the role or the scope of action that health stakeholders can play to improve budgetary dialogue. So I think this was really behind the initial idea of this work. I just want to underline probably another motivation for this work, which is the result of the IMF recent update to the definition of overall fiscal space. I think, as you said, it was very obvious that building on Sanjeev's expertise with macro fiscal policies, I think we wanted very much to digest, to understand better the new definition put together by the IMF on overall fiscal space, on the government-wide fiscal space, and probably to look at any possible implications, I would say, for health or for health sector spending. I think that was really the second motivation of this work. And I would say last but not least, as I mentioned on this slide, probably given how much the health financing landscape has changed over the past 15 years, so since the framework was introduced to us, and especially, as you said, with today's increased focus on domestic public resources for universal health coverage, I think we felt with Sanjeev that the timing is right for this work. And we hope that probably taking a fresh look today, in 2020, at this topic, so taking a fresh look at this idea, at this concept, at this topic will really help those of us, again, in the health community, to probably find or identify better practical ways, I would say, to align budgets, to align domestic budgets with the financing or the funding requirements for UHC. Next. So I think with this background in mind, we started this work some 18 months ago with colleagues from the World Health Organization and the Center for Global Development. And along the way, other colleagues, I want to note that, from the World Bank, the IMF, and other partners really joined the effort, joined the thinking, and provided really valuable inputs. And as I said, I think the initial idea was really to build on the IMF updated definition of overall fiscal space, but also to introduce this new notion of budgetary space for health, which I'll define shortly. And so with the objective in mind to really operationalize the concept, I think we provided input in three main directions or areas. One, or the first one, was really to link overall fiscal space to budgetary space for health in a consolidated framework and approach, okay? Then secondly, to break down the factors, the drivers, shaping budgetary space for health, specifically in low and middle income countries, and to try and quantify the impact of each of these drivers to really inform policy interventions. And in relation to that point, we wanted to explore further or to unpack the relationship between public financial management and PFM processes and budgetary space for health to ensure probably at country level a much more integrated approach, if you wish. Next. So I just want to give you a brief sense of what to expect from our presentation today. So the presentation is divided into four main sections, as you see here. So Sanjeev will begin by discussing the evolution of the definition. And then I'll present the consolidated framework, so really linking overall fiscal space to budgetary space for health. And then in the third part, I'll explore the connections, the links, the relationship between PFM and budgetary space for health. Sanjeev will then close by exploring some of the implications of this preliminary thinking for future research and policy development. So Sanjeev, over to you for the first part.
Thank you, Helene, for this introduction. Now, early 2000s was an interesting period. At that time, there was debt relief, which was being given. There was Grand Eagles when the G7 committed to double aid. All the debt relief was to be allocated to social sectors. And at that time, there was a discussion as to how one could come up with some fiscal space for social sectors. And so at the first definition, which of fiscal space was put forward by Peter Heller, who was one of my colleagues at the IMF for many years, and um, and he there were many other papers on fiscal space, but his paper is cited a lot more. So he defined fiscal space in 2005 as availability of budgetary room that allows a government to provide resources for a desired purpose without any prejudice to the sustainability of a government's financial position. And we will see how this definition has evolved. And there are some other definitions which were put forward in a number of documents at the IMF. But this one is cited a lot more, especially by health people. And then the reason why it is cited more by health people is because in 2006, Peter decided to extend this analysis to the health sector. And he said there are 5 ways to expand fiscal space for health. Now, a macroeconomist has some issues with the concept of fiscal space for health because there is no sectoral space. And we'll come to that in a minute as we start discussing. But Peter then defined the 5 pillars for fiscal space for health. These pillars included raising revenues, of course, when you have more revenues. In fact, what Helene is going to present subsequently will show that revenues is an important consideration. And also what Amanda said at the beginning, domestic resource mobilization is going to be an important consideration for supporting social sectors. He also said that improving the efficiency of all expenditure programs could generate resources for social sectors, and that's coming purely from public finance perspective. Yes, we know there are inefficiencies in a lot of programs, and if you were to reduce those inefficiencies, you will have resources freed up for use in the social sectors and for other high priority areas. And of course, the next thing that he talked about was, the third one was borrowing. That borrowing certainly enters the debt sustainability issues. And fourth pillar that he talked about, which to me is not a great thing, but it was seigniorage, because seigniorage is essentially the money which central banks make by printing money. You see, they are printing $100 bill, which costs 50 cents or 10 cents to produce. So the difference is seigniorage. So every year, the central banks transfer dividends to the treasury. And that is a non-tax revenue. So it's actually in some sense already covered in the first part. But seigniorage was not a very critical consideration. And of course, securing external grants. And that was important in the subsequent period because you could see whole amount of money for health coming in from external sources. Then the World Bank picked up this framework and did some work on it. And this was led by Tandon and Cashin. And they also picked up these 5 pillars, but they reset them in a different way. Instead of revenues, they took economic growth as being a determinant of fiscal space for health. Now, this relationship works only if the revenues are buoyant, because it's possible the revenue system is such that growth doesn't lead to additional revenues. And this is something that we are doing some work on, and we have a seminar on it next week. And so the second thing that they talked about was budget prioritization. The budget prioritization for health sector people means increasing the share of budget allocations in the budget. So it's not improving the efficiency of the programs, but it's really increasing the share. And it's clearly this was important because if you remember, there was Abuja Declaration. saying 15% has to be allocated to health. Not only there was Abuja, there was also Maputo declaration asking for more resources for agriculture. There was for education, and this was nightmare for ministers of finance. But anyway, these were the declarations that were made. And of course, earmarking of revenues. If you have social insurance funds, then you have resources for health. And then they picked up recognizing the inefficiencies in the health sector, that one could generate resources by improved efficiency of spending in the sector, and that certainly is valid, because there are tons of studies which have been done at the World Bank, at the IMF, OECD, which demonstrate using the efficiency frontier analysis or other frontiers, and I have done quite a few of them, which show that there are huge efficiency gains in the health sector that can be reaped if one were to do things differently. And of course, similarly, they had external resources. Then Helen in the WHO then applied this framework, Tandon-Cashin framework, which basically is a mixture of what Peter had and what the bank put forward to some 50 countries. And what did they conclude? They concluded that macroeconomic performance is clearly an important consideration that goes into providing more resources for the social sectors. And that is not surprising. If you have macro instability, everything goes haywire. So sound macro policies, sound frameworks create room for social sectors. They found that there was not much resources that you could get from earmarked revenues. That's not a major source of revenues, especially in low and middle income countries, because you don't have social assurance that prevalent, and earmarking by way of the cigarette or the alcohol taxes hasn't generated much revenues for various reasons. And increasing the share of the budget can, of course, provide some more resources, especially in the context of these global targets. And this final bit is a bit worrying to me, which is that there is, if you were to improve efficiency in the health sector, it doesn't necessarily translate into increased fiscal space for health. If that is the case, I think health sector will not get more resources down the line, because if they can't translate the inefficiencies into better use of resources, then some people can argue, why should you give more resources? So that's, to me, that result that you don't have efficiency generating more resources is not a positive sign. So let's go to what the fund did. And so there was...
Can I ask a question about that, Sanjeev?
Yes.
I don't know the Zeng thing. It strikes me that maybe that the empirical case is that the countries in question did improve efficiency, meaning they reduced the cost of delivering a given amount of health, and that the money was taken away by the Minister of Finance and given to education.
That is, in my book, that is fine, as long as the resource use is improving.
But then your criticism would not apply.
No. What they're saying is, the resources, in my book, if you are able to improve the overall resource use in the economy, it is fine.
Yeah.
Because, one can't be parochial, that the money must come back to the health sector. And if health sector demonstrates that it's using resources efficiently, then it certainly can get more resources from the ministries of finance. So the point here is that the health sector, from what I can understand by the summary of the studies, is that if you found ghost workers in the health sector and you removed those ghost workers, it didn't necessarily mean that the health sector was able to improve or convert those efficiency gains into
Health.
real fiscal space. So that's what we can discuss. This issue we had a discussion on in Montreux also, because people have some interesting views on it. But let me go to the definition, the new definition which was proposed in 2016 at the fund, and then it has evolved in recent years. The background was that at that point, there were a lot of definitions being used across different countries. And so the board wanted something uniform that could be applicable to all countries. And so they came up with this definition, which they defined as the room for undertaking discretionary fiscal policy related to existing plans without endangering market access and debt sustainability. So market access is something which has come into play. And this is relevant in Africa, for example, in 2017 or 2018. Africa region as a whole issued Eurobonds totaling $17 billion. So from countries from Benin to even some other smaller countries, Zambia, everybody is in the business of issuing. They have problems with debt sustainability now, but they have access to markets, and more countries are moving in that direction. So that definition, which is sort of much wider, it sort of has 40-50 criteria which go into assessing fiscal space, looking at the structure of the economy, and looking at the contingent liabilities in the economy. For example, if the country has a lot of non-performing loans in the banking sector, then if those contingent liabilities are realized, it is unlikely that the country will have much fiscal space down the line. So one has to take into account the extent of contingent liabilities. Take the case of Mozambique. It borrowed $1.2 billion in the last couple of years, which led to a big scandal. And I think for tuna boats, I think that's what they needed. They borrowed the money for, and those liabilities have now constrained the fiscal space in the country. You can also have issues with public-private partnerships, which many of the countries are going and getting engaged in. And those, in the absence of very solid frameworks, there is of course the risk that those liabilities will come to fruition down the line. So the framework allows taking all those considerations into account. So it has more than 50 indicators, and there are 4 steps in the framework, so it's dynamic in the sense that fiscal space today, let's say you were to spend some resources on priority sector, which then has an impact on growth, so which can create more fiscal space in the next couple of years. So it allows for that dynamic effect to be captured unlike the five-pillar approach, which is static. So this allows for dynamic effects of fiscal policies to be captured in the analysis. And one could disaggregate the approach for advanced economies, for natural resource-rich countries, for low-income countries, and so on and so forth. So you have different types of country disaggregation. And so, so this approach was applied, or has been applied, to 65 countries. Results of 34 countries were published in 2018. And in those 34 countries included Nigeria and Angola. And the results for the subsequent exercise for 31 countries have not been published, but I understand they were completed about a year ago. And so, and what did they conclude? There was some scoring which was allowed in the system, 4 scores, and it was that you could have some ample fiscal space, some fiscal space, little fiscal space, and then no fiscal space. And so in some countries, such as Pakistan, Nigeria, Argentina, very limited fiscal space. But generally speaking, they concluded that most countries had some fiscal space. So that kind of analysis, which is shown on the right-hand side for different countries, has allowed the teams and others to see the extent of fiscal space that is prevalent in the country. So what are the two takeaways from this? One is fiscal space is in an economy is determined by a multitude of considerations which interact with each other. It is not determined by 4 or 5 baseline conditions. And the considerations that go into the concept are country specific, and they are dynamic. And they go over 3-4 years. So this concept is good for, if you were able to carry out this exercise, then results of this exercise are good for 3 to 4 years. And second, the budget space for health, which is what Helene talked about it earlier this morning, is determined by the priority assigned to the sector through the political processes. And for example, Amanda referred to a number of case studies that we have carried out. All of them are showing, and I can multiply that with other countries, that the allocations for education are substantially more in those countries than for health. That's whatever the reasons for that. And then Helene is going to get into the considerations now that go into the budget space for health, and what does the country experiences tell us in this regard. So I'll pass it on to Helene and shift the slide.
Thank you, Sanjeev. Thank you, Sanjeev. So in this part of the presentation, indeed, I'd like to introduce the concept or the notion of budgetary space for health within the context of the overall fiscal space, and I'll try to unpack the factors driving budgetary space for health. So budgetary space for health is first determined by the annual public expenditure envelope. So this is number one on the slide, which is further influenced by overall fiscal space. Okay, and Sanjeev has just helped us understand the definition of overall fiscal space and its recent update by the IMF. So I'll not come back to these details. Because the new definition is dynamic, so as Sanjeev just explained, a new policy, and here I'll take the example for the health sector. So for example, expanding benefit package in the health sector can also create fiscal space through growth effects, as Sanjeev explained, and through other mechanisms. And so this is shown here on the slide by the green arrow. Right? Second, so budgetary space for health also depends on the share, as Sanjeev said, of the share of public expenditure envelope, okay, allocated to health, based on competitive budget negotiation processes. And so this is number two here on the slide. And although I think, and I completely agree with Sanjeev, it's often a political decision, the share dedicated to health may also depend on the quality of budget development, its formulation, costing, and its linkages with the results framework. Last but not least, and this is where this third step that now Sanjeev is showing to us is important. So we argue that budgetary space for health depends also on the effectiveness and the flexibility of the PFM, of the public financial management system. So number 3 here on this slide. Okay, the availability of resources within our sector, within the health sector, depends on how budgeted funds are allocated and then managed and then executed and then implemented in the sector. And I think the inclusion of this third step, of this third pillar in budgetary space for health is really critical to have really a comprehensive view of what budgetary space for health is for us. And then the red arrow, you can display it. Next click, thank you. So the red arrow beside this step shows how the efficient use of resources by the sector can then impact the future level of public expenditure dedicated to health. Click, please. So I think, in sum, the notion that we want to introduce here, so this notion of budgetary space for health or budget space for health tries to really reflect the production process of budgeted resources for health that are derived from the overall expenditure envelope, budget allocation decisions, and then rules and practices for budget use, which is basically public financial management. And I think this is really a comprehensive definition that hopefully reflects, I would say, the realities of public finance processes and mechanisms, and can help, hopefully, health authorities to better delineate their scope of action or where to fit within these processes and mechanisms. Next slide. So really building on the framework just described and really following this logic, it's then possible to, I would say, estimate or quantify the contribution of the different factors, of the different drivers that shape the change in budgetary space for health. And so we talk about this as a budget decomposition analysis, okay? And so in a nutshell, the approach consisted of identifying the change in overall expenditure that is further decomposed into revenue, borrowing, and other sources of financing, and the change in the share of the budget dedicated to health. And then we determine how these two changes, okay, shape budgetary space for health, which we estimated in a very simple manner by the change in per capita public expenditure on health. Obviously, more details in the background paper, and we can share it shortly. But just to say that this was really a simple way that can be also replicated in any context to really understand the drivers behind budgetary space for health, because we had this idea that not all drivers actually shape budgetary space in the same way, to the same extent. Okay, so it was really the idea to unpack and quantify the different factors. And so we applied this approach to 82 low and middle income countries from between 2000 and 2016. Why 82 low and middle income countries only, you would say? Actually, we wanted to cover all of them, but we had some data inconsistency and missing data on the revenue side for a few low and middle income countries. So that's why the set is 82 low and middle income countries. Next slide, thank you. So the analysis, our analysis found, perhaps I would say unsurprisingly, that the overall level of public expenditure is, the main driver of expanded budgetary space for health. So about 70% of budgetary space for health is generated by change in the overall level of expenditure in this sample of countries. Okay, this is the green section on the graph you see. And about 30%, this is the blue section, 30% of the change is directly attributable to a change in the share of the budget allocated to health. And so as you can see on this graph, the analysis really showed consistent patterns which emerge by income level. So the impact of budget share, I think it's 31% in low-income countries, 23% in lower middle-income countries, and 31% also in upper middle-income countries. Next slide. And I think even probably more interestingly, the analysis found large variations across countries around specifically the impact of budget share on the expansion of budgetary space for health. So what we found was that in 15 of the 82 low and middle income countries that were part of this analysis, the share of budget allocated to health contributed to more than half of the expansion. So huge contribution. But actually, in the majority of the sample, the contribution was far less. In general, below 20%. In addition to that, and I think this is really a critical finding of this work, I would say, despite the probably widely held belief that increased budget share significantly improve fiscal space for health, with the Abuja target in mind, as Sanjeev mentioned, what we noticed is that actually the actual impact of budget share or of a change in budget share over time has a quite limited effect or impact on budgetary space for health expansion. Okay? The other, I think, important finding was related to the fact that the contribution, I'm still on the previous slide, sorry. The contribution of budget share to budgetary space for health expansion actually decreased or is decreasing in recent years in most low and middle income countries. So just in terms of the final word from this analysis, at least my own takeaway that I would like to discuss with you, if time allows, is that I think the findings put really the role of budget prioritization that has been really at the forefront of budget advocacy strategies, right, for the past 10 or 20 years. So I think the findings really put the role of budget prioritization into perspective, and I think somehow underline some of the limitations of this approach, of this pillar, despite its, I would say, real importance for the political visibility of health in budgets, but in practice, it doesn't bring much for budgetary space for health expansion. So really something that should capture our further attention. Next slide. So let me now turn to the relationship between PFM, public financial management, and budgetary space for health. As I noted when describing the budgetary framework initially in the previous slides, I think this is really important. Budgetary space for health does not only depend on changes on the overall level of expenditure or changes in the share of the budget. Okay, it also, at least to us, and from the evidence that is really emerging in recent years, it also largely depends on how these funds that are allocated to the sector, are actually managed. Okay, and this is really the third step or the third pillar in the budgetary framework that I've put here. It's the red part on the slide. And just to say that historically, I think that budget space or fiscal space and PFM, I think Sanjeev won't contradict me here, but they have been viewed as two separate concepts or two separate disciplines, if you wish, each with their own separate communities of expertise and experts. But I think in our recent discussions with experts in Montreux and in other occasions, there is an increasing consensus that these two notions are really quite closely linked. Poor PFM is not only a constraint for fiscal discipline, it's also a clear bottleneck for budgetary space. If you just take the example of, I would say, late or incomplete or misaligned budget releases, it's obviously a constraint or a limitation for budgetary space or the financial margin within the health sector. So I would say perhaps more than in any other sector, these two separate concepts of fiscal space, if it exists, and public financial management, which was very much focused on the expenditure side. So these two notions should be considered now together to really maximize the existing budgetary space and to potentially create even more space for the sector. Next slide.
Can I ask a clarifying question, Helene?
Sorry, I still have this slide.
Okay. It's a question about
Yeah.
PFM per se. I mean, obviously, are you talking about expenditure efficiency? So first, the ability to execute expenditures, which is how I would think of PFM,
That's right.
versus doing it efficiently, which is,
Which is-
PFM plus a lot of other stuff.
That's right.
How, do you distinguish
Yeah.
those two things, or are you thinking of those under the same rubric of PFM?
I think here, and this is probably the next slide, we take the definition of PFM through the standard critical budget cycle, so from how expenditure are formulated in budget and then implemented. This is, I would say, the administrative efficiency, if I may say so. So this is really focusing on public finance processes. So without probably going into the details now, probably in the interest of time also, but I think there are many moments, as I said, within the budget cycle where public financial management, so PFM interventions, to also answer Amanda's question, can really help expand budgetary space for health. So just consider budget formulation, for example. Formulating budgets, I would say by programs or around this idea of outputs instead of inputs, may generate more flexibility in the use of resources within the health sector envelope. I'm not speaking in terms of even increasing the envelope, but within the same sector envelope, and therefore help improve budgetary space for health in that sense. I think the same idea applies to budget execution. Improve budget execution. It's very simple. I mean, it's quite difficult to address, but I think the notion is quite easy to understand. Improving budget execution can help expand budgetary space by just reducing the level of unused revenues in the sector. Over to you, Sanjeev, for the conclusion.
Thank you, Ellen. This is very helpful. I'm just going to pick up some of the key ideas that have come out from the presentation. And when we talk about incorporating PFM in budgetary dialogue for health, we must recognize that, in many, many countries, I would say virtually all countries, health ministries don't really execute most of the budget. There's a lot of funds which stay unused. So clearly, some PFM improvements and better usage of the existing funds can make a big difference in creating space in supporting existing programs. So I think So it's and in this regard, it's important that the Ministry of Health proactively engages in the PFM reforms. I mean, they have to make their needs felt with the Ministry of Finance, which is engaged in designing the budget law, and or if there are some issues with the budget law, they should be making that known to the Ministry of Finance that doesn't work for the Ministry of Health. And increasing the share of health sector in the budget clearly has to be seen against the historical context. So the data that we have presented shows that really 70% of the increase that has happened in the health sector, the spending, it has come from the spending side, which behind that lies increases in revenue. So going back to the statement that was made by Amanda at the beginning, raising more revenues will make a big difference. And if you look at the performance of countries since Addis conference, there is no change on average. On average.
No change in execution.
No change in revenue performance.
Revenue.
So there is an issue that we need to put more emphasis on, and it could be a whole lot of factors, and some of them are deeply political, and we've been highlighting those in various outputs that we've produced. But despite the fact that there was an Addis tax initiative in which all the donors committed to double their technical assistance by 2020 to the countries. So they decided to shift a lot of resources from aid to technical assistance. And the numbers that we have seen for the last couple of years, they are on track to spend more and more. But one is unclear whether that is having an impact at this point. So, and if one looks at the numbers which the fund has produced, they are saying that on average, to achieve the SDGs by 2030, the developing countries, and I will talk about low-income countries separately, would need on average about 5% of GDP in additional revenues, which basically means 0.5% of GDP every year until 2030. And that is not going to happen. The amount of resources needed by low-income countries is much larger because they are starting with a lower base. So their estimates for countries such as Benin and Rwanda, they need a lot more money when you start disaggregating the resource needs. So, so one should look at the performance of countries, what they have been doing in the past, and then set up realistic goals, and then focus on the drivers, as Helene has been talking about. And, you know, one doesn't have to do country-level assessments, which has been in fashion or in vogue in the last 10, 15 years, but rather sort of start engaging with the ministries of finance in the multi-year budget context by putting forward realistic, reasonable budgets of the health sector, and making sure that the implementation is complete. And if one were to do it systematically, one would expect that budget share dedicated to health will go up. And of course, there's a lot more work to be done on the sectoral level, on the PFM side, but the papers that were presented in Montreux in November showed that, as I said earlier, the execution of the budget is pretty dismal in a number of countries. I couldn't see in the list of countries that they showed where the budget execution was total. And this I knew from my experience at the IMF, where I was looking at the budgets, and health ministry was not, and then it's not very convincing for Minister of Finance to allocate more resources if they're not able to implement the existing plans. I'll stop there. Thank you.
Thank you, Sanjeev and Helene. I think these points, and I think also if you reflect on the desire for more co-financing from governments that a lot of the big funders are asking for, and doing it on a disease-specific or condition-specific basis, you can see where we're presenting a very inarticulate ask to ministries of finance, also given under execution in the health sector as it stands today. So now let's go to you for your questions and comments. Start with Austin.
Do you want us to introduce ourselves?
Yeah, please say who you are and where you work.
Is this on? The green
Yes,
one?
it's on automatic.
My name's Austin Davis. I work with the Norwegian Development Corporation, NORAD. So my questions are for Helene. I don't know if she can hear me.
She can hear you, yeah.
So,
Sure.
So Helene, well, I think the first thing on budget advocacy, I note that Tedros in Davos is already asking for incremental increases by 1% instead of fixed budget goals. So I think you're already moving there. So congratulations on that. My questions to you were, so you've shown this kind of cascade down from overall fiscal to budget and budget for health, and then execution. And you showed some feedback arrows, but I didn't find your analysis really put that into place, and I think it might be helpful. So, did you look at the association between budgetary efficiency or execution or some form of budgetary performance and the degree to which that impacted on budgetary allocations, increased budgetary allocations? Because I wasn't clear, the few countries where there was an increase in budgetary allocation, was that due to a political process of prioritization, or was it due to increased confidence that the ministry can budget well and spend money well? Because if there is a feedback loop there, that would be important to try and demonstrate. And my second question refers a bit to what Amanda was saying, that in terms of budgetary efficiency, you've got two things. One is how well you spend the money, and the second is what you spend it on. And your analysis looked at how well you spend the money. If you were spending it on better things, you would imagine that they have a stronger feedback loop to promoting overall growth, and therefore growth in potential space. And if you could demonstrate that, that might also increase the chances of higher budgetary allocations. So I think your model would be more useful for ministries and more a greater incentive for them to change behavior if you could reinforce those feedback lines, both up to allocation but also up to total revenue.
It's a good idea. And I think, when you look at the economic case, for example, that Gabby's making in the last couple of days, that's sort of the concept, right? But we need to link the actual execution to those expected health impacts associated with interventions. Other comments? Mead, we'll take one more after this. Go ahead. Keep it short.
I think this is on, right? So I find this fascinating. First, the small comment is when there's unexecuted budget, it strikes me that is the purest definition of budgetary space or fiscal space in health. And, one should start there. The 65 elements that you need in order that the IMF is using, it strikes me that one should start there and ask how much more budgetary space might there be above that. And anything that's above that requires changes in national preferences, as you point out, Sanjeev, as well as improvements in public financial management. But then the other issue, The distinction between discretionary and non-discretionary spending seems to me to be critical in the IMF's approach. And part of non-discretionary spending, or part of what I believe is considered a constraint, like non-discretionary spending, would be contingent liabilities. So an example here, in middle-income countries at least, would be pensions. That's usually considered a non-discretionary part of the budget, and it could be considered a contingent liability as well. And we usually think that that constrains fiscal space, and I believe that that's part of the IMF analysis, if I understood correctly. In the area of health, I've argued that when you put a person on life-sustaining treatment, that's a contingent liability. So whether it's kidney dialysis or AIDS treatment, once that person starts on that treatment, removing that funding to support that treatment is, I would argue, analogous to taking away a person's pension, and therefore it's non-discretionary. And I'm wondering whether your analysis, either the IMF analysis or the analysis that Helene is contributing, has recognized the contingent liabilities in health and the processes by which what might be a discretionary spend now gets turned into a non-discretionary spending item by, for example, the UHC initiatives, and whether that process might be different places in different countries, and it requires explicitly recognizing that room for discretionary spending, which is what you're defining as fiscal space, actually is decreased by permanent commitments, which are analogous to pension commitments.
Now, this idea has been out there for a while
I know.
and has not
I-
had much love, I must say, from the fiscal macro people. It'd be interesting to hear what you think about that. One more question or comment? Go ahead.
My name's Chris Lane.
Yeah.
I've been at the fund until, well, just a couple of months ago I left, but I've worked, it's very good to see this history of fiscal space for health, because I've worked on it on and off over the past decade. My question was, would it be worth looking at health outcomes as well in relation to, in part, public spending, but probably you'd also have to take into account the amount of private spending going on. And I'm thinking of the recent work that's been done at the fund, which looks at SDG scores calculated by Columbia and links it to the amount of public and private spending by sector, including some analysis in health. They're trying to do a lot, and I wondered if it's worth drilling down more into the health sector and looking at the frontier countries that are actually spending relatively little on health but getting very good health outcomes. And I was, of course, thinking about this country where they're clearly spending too much on health and getting very poor outcomes. But there are stories like that in low-income countries and middle-income countries and lower-middle, whatever. And it would be nice to tease that out as part of the motivator for spending more or less, perhaps, on public spending on health, just as a thought. And I think there are problems with the SDG scores, but it's not a bad place to start because there's a lot of data out there that sort of aggregates health outcomes and tries to give country scores. But you could disaggregate it as well and say, well, we're doing well in some health indicators given our level of health spending, but not others. It's a slightly different direction, but I think it'd be very interesting to do. Turn that off.
So let's return to Helene and Helene and Sanjeev. Do you want to start, Helene?
Sure. Thanks a lot for the very good question. So maybe very briefly on the first question on the links between budget execution or budgetary performance or PFM performance, if I may say so. So the links between these and a potential increase in budget share, no, it's not yet included in the study. I think it would require then a qualitative approach at country level to really be able to understand the story, whether an improvement in budget execution would actually be would have some convincing power to then increase the level of the share of health within the budget. So, but no, it's not yet included in the model. But I take note, and I'll put some thinking on how possibly to integrate this. That's noted. More specifically on Mit's question, and again on budget execution, actually, and probably that's how also budget execution is also central to this piece of work on budgetary space for health, is because also we are doing another work program specifically on budget execution issues in the health sector. And in this other work stream that I do with the World Bank colleagues, we really look at the depth and the breadth of budget execution issues, specifically in the health sector. And now we have a sample of more than 50 countries. So consolidating budget data, execution data, which were quite difficult to put together. So for me, it's a separate piece of work. But now with your question, I'm trying to think how to better probably integrate some of the thinking of some of the findings that we have as part of the budget execution work into the budgetary space for health thinking. And then very rapidly on the last comment or question, it reminded me actually some very recent work by other colleagues from the WHO showing actually that higher public spending on health is actually associated with higher service coverage, but not with higher financial protection. And remember that these two components, so service coverage on one side and financial protection on the other, are actually the two components now that we use somehow globally to measure progress towards universal health coverage. So for me, this work is already starting, and we were also part of the thinking, but really showing that there is somehow a disconnect at some point, I would say, of the policy implementation towards UHC between an increase, let's say, in the level of spending or an increase in the budgetary space for health, if we want to reconsolidate the two thinking, and then no direct or systematic impact in terms of outputs measured from a UHC perspective. So, yeah, more work to do on this, but I think there is some new evidence coming here that we need to monitor further. I'll stop there.
Thank you. Steve?
I think my general comment is there's many good ideas but this is just a proposal of a framework. So I think one can extend many of the issues which have been raised in the subsequent research. But picking up the question that Mead raised, I was involved with Amanda in some of the seminars and meetings on turning HIV commitments into contingent liability for the government. I don't think that flew very much in the policy discussions, and Paul Collier was pushing for this idea as well, and it didn't really go very far. And but your comment on pensions being contingent liability, yes, it is in the framework. I didn't mention it. I just took one example of non-performing loans for the banking sector. It can also include the constraints imposed by aging, because demographics are changing. Then going forward, you could think of your spending on health going up because people are getting older. So, and there was some analysis which I was involved in doing where we projected the spending on health for some of the major countries in the world, for 80, 90 countries, and it does go up. So countries have to recognize that this spending is going to go up, and that contingent liability has to be taken on board in the analysis that you carry out. But I think the suggestions from Chris and all those, but linking at this point with outcomes is going to be very hard in this framework. But ultimately we will have to do it. But it is something we should do it in the next stage.
Okay. Well, I think we'll have you back, Helene, to talk about the execution of expenditure work with colleagues from the World Bank. I think that sounds really interesting. And I think it is worthwhile for us to reflect on what this means for external support to this area of domestic resource mobilization and budget prioritization and civil society accountability for budget execution. You know, how well are all those working vis-a-vis this kind of thinking? There's a big health financing initiative with African leaders through the AU. So I think it is worth taking a moment and contrasting what we know about what drives expenditure space now versus what we're supporting and thinking is going to work for that. But also I would say on this issue of treating it as non-discretionary spending, I mean, a good health insurance fund takes into account that whenever they enroll someone or they offer some new benefit, they have to finance it, not this year, but they have to finance it for the entire duration of that person's remaining lifespan. And that is what a good actuarial analysis looks like. I don't think that many of the insurance funds as they're set up today in middle income countries are doing that in a very dynamic way. So I think that is something, but it also has a feedback on growth because there's more productivity, as Austin was pointing out, et cetera. So these are all things that that are an agenda for the future, I guess, that we should think about. But thank you so much to you for coming out and to our audience online and to Helene, the World Health Organization, and Sanjeev. So thanks. Great work.
Thank you.
Thought-provoking.
It worked well.